Good evening, everybody. Today we have Professor Jayanti ma'am and myself doing the clinics. Yeah, Professor Jayanti ma'am is expected after some time. Ma'am is already there, so we can start. Good evening, ma'am. Good evening to. We are not able to hear you. Okay. Good evening, everybody. Welcome to this edition of PG Clinics. And today we have Isg on pancreatic disease. To discuss this case, we have Dr. Kushan from Apollo. Dr. Kushan, are you there?
Yes, sir.
Okay, fine.
Good evening, sir. I'm there, sir.
Dr. Karthik is there?
Yes, sir. Good evening, sir.
Good evening. Dr. Chetna?
Yes, sir. Good evening, sir.
Good evening. Dr. Vivek? Okay. Dr. Rohan?
Good evening, sir. I'm there.
Good evening. Dr. Ravi? Ravi Kiran? Okay. 4 people are there, 2 are there. And for backup, we have Dr. Karthik and Dr. Ashok from Believers Church, Kerala, and Dr. Amit from KIMS also. Can we start? Dr. Kushan, are you ready?
Yes, sir. I'm ready, sir. Good evening, sir. Good evening, ma'am.
Good evening. Today's format is Isg style. We will show you a short case history and ask you how to go about it and show you some findings. Again, ask you what is the diagnosis, show you some investigation. Again, ask you the interpretation and may ask you to do suggest the investigation and the management part. And we may ask some other additional questions as well. Okay, so we are proceeding. Okay, please start.
Yes, this is a 46 years old male. He's a businessman. He's a regular. He consumes regular alcohol, 4 pegs, twice to thrice weekly for the past 10 years. And there is also occasional binge drinking. There is no features of withdrawal when he stops drinking. And the last binge was 1 month ago. A severe abdominal pain, upper abdominal pain, 2 days later, associated vomiting. Pain was very severe, making him to and no jaundice. He had to be admitted. Sorry, sir. Yes, sir. The pain relapsed on the second day. He developed breathlessness on the third day and hence was referred to the second hospital. On arrival at the emergency, his tachypneic, it is 28 per minute. The pulse rate is 130. BP is 100/60, and there is no icterus. The abdomen is tense. There is diffuse tenderness. There is no rigidity and mild guarding. The chest diminished air entry in both lung bases and sparse crypts are present.
So with this history as well as physical findings, what do you think? You are dealing with what sort of an issue?
Sir, the patient has an alcoholic use disorder and now he's presenting with acute pancreatitis, and he also has symptoms suggestive of SIRS because he has tachypnea and tachycardia.
Tachypnea, tachycardia. Okay. Plus any other additional things?
Will it be more of an acute on chronic, or everything is acute?
Is it? Yeah, that is it. Because
in alcohol consumption, normally we don't say acute, no? It's always an acute on chronic because already there's pre-existing chronic injury to the pancreas.
even though clinically he might not have had evident acute pancreatitis, he might be having changes of pancreatitis in his pancreas. So though it produces clinically recurrent acute, technically it is
acute on chronic.
Basically acute on chronic. Okay.
You think it is severe? What do you think? Is mild, moderate, severe? Always classify, no? Classify. Based on the clinical presentation, you think is acute, moderate, or severe? Give a complete diagnosis.
Yes, sir. Yes, ma'am. So it is classified according to the Planta classification, ma'am. So since we don't have the other organ failures,
At least respiratory is not there.
like the oxygen requirement, ma'am, the renal failure, and also the yes, ma'am, will require.
Okay, so you think this
Karthik, take
patient?
over. His audio is not okay. Karthik?
Yes, ma'am.
Yeah, just take over.
Ma'am, yes, ma'am.
It got disconnected. Ma'am, so to classify the organ failure, ma'am, the 3 organ failures will require a little more investigations at this
Yes,
point
please, not
of
mine.
time, ma'am.
Okay, you require some more investigation. Okay.
And
Kushan, your audio is having lot of problems.
also, we need to see whether. Yes, sir. Am I
Okay.
audible, sir?
Yeah, now audible.
Okay.
Please continue.
Yes, sir. The WBC count is 14,600 and neutrophils are 65%. The platelet is 2.4 lakh. The hemoglobin is 9.8. PCV is 48% and ESR is 48. The CRP is 210. The sodium is 138. Potassium is 4.5 and calcium is 8.2. Urea is 56. Creatinine is 1.1 and RBS is 156. The LFT, the total bilirubin is 1.1, conjugated is 0.6. AST
Okay, LFT
is
normal.
32.
LFT is fairly normal. Okay.
Yes, sir.
Okay, from the blood parameters, can you assess the severity? Is there anything in the blood parameter? Okay, his saturation was around 92 when he came to hospital. Had to be given oxygen at the rate of 6 to 7 liters per minute, and then only it became 95%. And he was tachypneic on arrival to the hospital.
Okay, sir. Sir, the creatinine is 1.1, so there is no renal failure, sir. And also the blood pressure, the systolic blood pressure is more than 90, so there is no cardiovascular failure also, sir. Only the respiratory system is involved, sir. And since the patient has presented after the second day, so it is persistent for more than 48 hours, sir.
So, what do you think about this hemoglobin? Is he having a hematological disease?
Sir, it could be because of hemo concentration, sir, because the PCV is also elevated, sir.
So, are you not concerned about that? What
Yes,
does that
sir.
suggest? Because he came to the second hospital on the third day, 2 days in one hospital, and there is intense hemo concentration. So, what should have happened in that hospital?
Sir, pancreatitis itself can cause hemo concentration because of third space fluid loss, sir. And secondly, the patient was having vomiting also.
Okay. So, probably that fluid, not enough fluid was given. The most important thing in the management of acute pancreatitis now is hydration.
Fluid management, sir.
Okay, lavish hydration, because that probably they followed a very stringent criteria to give fluids. That is probably the reason. So a high hemoglobin, high PCV should make you think of that hemo concentration, and CRP is 210, that's elevated. What is the role of urea in the prediction of severity of acute pancreatitis?
Sir, it is used to calculate the bicep score, sir. So the blood urea nitrogen more than 25, it is one of the criteria for the bicep score, sir.
Okay. Now look at the physical finding.
Calcium?
Calcium is, yes, ma'am, 8.2. It is mildly low, ma'am.
So it is also low. It is below normal. It is below normal.
Below normal.
Yes, sir.
You have some parameter like TC elevated, hemoglobin elevated, PCV elevated, creatine, CRP is high, urea is slightly high, calcium is on the lower side, LFT normal. Okay. So you are given the ultrasound finding also. So look at the.
The liver is normal. The GB is partially distended. There is no gallstone, and the CBD is 5 mm. The pancreas appears bulky, hypoechoic, and there is no fluid collection. Mild ascites is there, and mild pleural effusion bilateral is present.
Okay, so this is what is available to the ED doctor, and how do you decide to manage now?
Yes, sir. So, sir, this
okay,
patient has.
Before that, I will ask you, what are the criteria by which you assess the severity, and how do you prognosticate? You said about bicep score. What is bicep score?
So the bicep score has 5 components. So the B stands for blood urea nitrogen more than 25. I is for impaired mental status. S is for SIRS. So this patient has more than 2 out of 4 components of SIRS. Sir. A is age more than 65, and P is pleural effusion. Sir. So this patient has pleural effusion, and this patient has SIRS, and the BUN is also likely to be more than 25, sir. So his bicep score is 3 out of 5, sir.
Okay. So then how do you proceed now?
Yes, sir.
You are
Sir,
the doctor in charge.
yes, sir. Sir, the patient has acute on chronic pancreatitis. So the management I will divide into so the management for the hydration. The second part will be the management for the pain, and the third will be provision for nutrition, sir.
Okay, good. So hydration, what is the principle of hydration?
Yes, so the hydration is started with 20 ml per kg, sir, as it is given as a bolus, and subsequently it is given as 3 ml per kg per hour, sir. And this is mainly followed up to 48 to 72 hours, sir, and subsequently it is done according to the urine output and the hemodynamic stability of the patient, sir. So
Okay.
the target is generally, sir, MAP of more than 70, and IVC diameter. It should be targeted as more than. I mean, if it is less than 1.5, it means that more fluid needs to be given, sir.
Okay. What are the clinical pointers which will tell you that enough hydration is not happening?
So the BP, the blood pressure of the patient will be low. The patient will continue to have tachycardia. The urine output will be less than 0.5 ml per kg per hour, and the IVC diameter also, sir, it will be less than 1.5 centimeters, sir.
Okay. Now, what is the second part? Hydration you have done. Next.
Sir, the second part is the pain management, sir.
Okay. So for the time being, we will not look into that details. What about nutrition?
Yes, sir. Sir, nutrition, if the patient has mild to moderate pancreatitis and he is able to take orally, sir. So once the pain subsides, we can start the patient on oral nutrition, sir.
Suppose somebody is having very severe pancreatitis, he is having vomiting, ileus, so many problems are there. How will you provide the nutrition?
Still, in that case, sir, enteral nutrition is preferred to parenteral nutrition, sir. So we can put a nasogastric or a nasojejunal tube and feed him with that, sir.
Okay, so you don't think giving rest to the pancreas is not needed? Nutrition. So what is the difference between giving rest to the pancreas hypothesis versus early enteral nutrition? Does it enteral nutrition give any advantage to the patient?
Yes, sir. I mean, early enteral nutrition has been found to reduce the subsequent development of complications, sir, and
Yes.
it helps in maintaining the barrier.
Okay, it
epithelial
helps to
barrier,
maintain
sir.
the microbiome of the intestine properly, and probably less complications happen. Okay, next slide.
So one thing is that in case a patient has worsening of pain, you're feeding, then you have to withhold it. Okay. If the pain does not worsen and he's able to tolerate, then you continue with the oral feeds. But if the pain sets in and he feels it's painful when he takes some meal, then you'll have to withhold the oral feeds. So you have to tighten that.
Okay, what analgesics you give? Did you hear me? Dr. Kushan, are you there?
I think just take out.
It has been found that.
Yes.
Yeah. Hello, sir.
Yeah.
Okay, it's
sir, I'm able to hear, sir.
Yeah, okay. But what analgesics you give? Again,
sir, we generally prefer, sir, we prefer non-opioid analgesic, but in the trial it was found that opioid analgesic pentazocine was compared with diclofenac, and it was found to be more effective.
What would you give, doctor? Just tell what you would give.
Ma'am, I will start with non-opioid analgesic like paracetamol, and subsequently, if the patient continues to have pain, ma'am, in that case, I will start with opioid analgesic.
Can you answer like this, no? See, the last case is actually a viva, so please mention the dosage how you would give, how would you monitor. Don't make blank statement, like that you'll give paracetamol, you'll give this. Always mention his dose. The last case, it comes from the DMB office. So last case, direct, it is you confront the examiners, okay?
That case is managed by the remote examiners or the local examiner. The last case
Exactly. The last case is monitored by the local examiners.
monitored by the local examiner, but questions are all set by the national board.
National board, yeah.
Okay, so you have to know the management thoroughly. There should not be any doubt about it. Okay, assessment of the severity, assessment of the progression of the patient, and all predictors of acute severity of acute pancreatitis. Apart from BISAP score, there are other scores as well. Prognosis scoring systems. Okay, on the 5th day, this is a CT. They did a CT on the 5th day. In fact, is there a role of doing a CT scan, or can you just manage like that with an ultrasound?
Sir, if the diagnosis is in a doubt, only in that case, CT is indicated, sir. Otherwise,
if the ultrasound did not show anything, you want to do. But if the ultrasound showed there is bulky pancreas and the patient condition is still not in a good shape, is there a role for CT?
Sir, in that case, to look for local complications, sir, we can plan a CT after the
72 hours.
Third day.
After third day. Why can't you do it on the day one itself? Because your diagnosis will be easier. Otherwise, you will be in darkness, no? Why can't you do it on day one itself and finish with that?
Karthik?
Sir, probably after the third day, sir.
Okay, my question is that why are you not doing it on the first day? You have a CT scan, the patient is in the ground floor on day one, and it is easy to move to the radiology room, finish it up, and then go to the ICU or wherever it is.
Necrosis.
Sir, it will give an inaccurate estimate of the percentage of the pancreas that is involved, sir.
Because it will evolve. The correct time is after 48 hours, and probably 72 hours may be the ideal.
Necrosis.
Okay. Second thing, you have to be careful about the hydration and other thing. You have to well hydrate the patient very well. Okay, then only you go and do this. And the etiology part, also if you do by the third day, if the stones are missed on ultrasound, you'll be able to find out on CT. Your ultrasound is better sensitive for detecting gallstones compared to CT scan. Okay, so look at this CT scan done on 5th day. What are the findings?
Yes, sir. There is bulky pancreas with heterogeneous post-contrast enhancement of the parenchyma of body and tail, necrosis of body and head, and necrosis of the tail region, and fat necrosis of the adjacent areas. Pancreatic duct is normal. There is mild fluid collection adjacent to the pancreas anteriorly in the perigastric left perirenal area, and the both paracolic gutters, and mild ascites is present. The liver CBD is normal. There is bilateral moderate pleural effusion with atelectasis of the lower lobe segments, and kidney is normal. There is no stone. Portal vein, splenic vein, and SMV are normal. The CTSI score is 6.
So what do you think? Is it?
Sir,
there is?
Sir, he has a acute necrotizing pancreatitis with acute necrotic collection, sir.
Okay, so he has got necrosis as well as collection slightly away also, because he has collection in the paragolic gutters. You can expect peripancreatic fluid collection in and around pancreas, but he has got a fluid collection slightly elsewhere also, no? Plus bilateral moderate pleural.
Yes, sir.
So why do you think that he has got developed moderate pleural effusion? What is the cause of that?
And bilateral.
Bilateral. What if he has got unilateral, and what if he has got bilateral?
There could be a sir, usually unilateral is because of reactive pleural effusion on the left side, sir.
Okay, so the left side is much more common.
Bilateral is because of yes, sir. Bilateral, sir. It could
Kushan, we actually have something to hear you.
With left side more than right, and also if there is a fistula, in that case there could be bilateral.
Okay, left side.
Sorry, sir.
The question is bilateral, no? Don't discuss what is unilateral, no? So just see whether you can give some explanation for the bilateral. That's all. It must just be an inflammatory response in the diaphragm. No, that's all that you can explain. There's something in
Yes, sir.
bilateral. Otherwise, you cannot explain it. No, bilateral. It's not possible that he has a fistula on either side. It's only possible on the left side. No. So therefore,
Yes, sir.
question like this is asked. Answer to that question: why is it bilateral? That's all that you're asking.
What are the situation in which a severe acute pancreatitis or a moderately severe acute pancreatitis patient develop bilateral pleural effusion?
That's all. That's what you're asking.
Yes, sir. So
Yes. It could be due to
yes, it is
Yes, sir.
reactive pleural effusion, or it could be because of fluid overload.
fluid overload produce pulmonary edema, not pleural effusion. No. Karthik, what do you think?
Sir, it could be because of irritation of the diaphragm, a transdiaphragmatic leak, or it could be because of a pleural pancreatic or pleural fistula, sir.
Okay, pancreatic pleural fistula is mainly on the left side, and irritation of diaphragm perhaps can occur on both sides, especially this patient has got evidence of collection of fluid elsewhere. So that means fluid would have swept to other parts of the abdomen, and that would have produced irritation.
Yes,
Can SIRS produce pleural effusion? Yes or no? It is
SIRS
unlikely. It produces more of parenchymal changes, no?
yes.
Interstitium of the lung. Okay, pleural effusion is again unusual for that. Okay, now we'll move to the next part. You have to revise Atlanta use of management acute role of. Is there a role of antibiotics? When do you decide to give antibiotics in acute pancreatitis? Is there a need?
Yes, sir, if there is a infected collection in the in acute pancreatitis, or if the patient has cholangitis, or there is another focus of infection like a urinary tract infection or a pneumonia, in that case antibiotics are given, sir.
So how do you decide whether the fluid is infected or not? What are the clinical pointers to that?
Yes, sir, if the patient has improved and then subsequently deteriorated in the and he develops new onset organ failure, sir, along with hypertension and tachycardia, and there is also increase in the WBC count and the CRP. In that case, we will clinically suspect.
So the patient who is in the acute phase of the infection, acute phase of the disease, like acute severe pancreatitis in the first week, fever continues, and his general condition is not improving. There is a doubt whether there is infection or not. What are the statistical chance that he can have infection in the first week? Infection in the peripancreatic fluid.
Sir, usually in the first week it is less common, sir.
So when is it common?
Sir, after the second week, sir. Generally after the second week.
So the patient may improve or may not improve, but infection usually set in by the end of second week. So in the first week, it is generally SIRS, etc. Is there any? What are the other methods by which you try to find out infection indirectly, other than cultures?
Sir, in the imaging can be performed, sir, an ultrasound or a CT, and if it shows a gas in the necrotic collection, that is also suggestive of infection, sir.
Okay, so you said presence of cholangitis, then presence of infection elsewhere in the body, and maybe at the end of second week, if you suspect there is infection in associated with the fluid collection. Okay. Now, these are the various criteria. This today actually I have only copied from Schlesinger because you have to read Schlesinger, that is more than enough. Okay. So Apache to Glasgow, Emery, Bissap, SIR score. Are you aware of the SIR score?
SIR score, sir, the systemic inflammatory response score, that is composed of the four elements, sir. The temperature, there can be hypothermia of less than 36 degrees or hyperthermia of more than 38 degrees. Tachycardia, tachypnea, and
okay, just be aware of this various scores. Okay, thank you. And then this is the grading, that also one has to be thorough, and of course the management of acute pancreatitis. Thank you, Dr. Kushan. Now for the remaining part of this case, we will discuss to Dr. Karthik from Apollo to take over.
Yes, sir. Okay. Good evening, sir.
Dr. VT, one question from here. Can we say third space fluid collection in the pleural cavity?
Pardon?
There's a question in the chat box for this up to here, can we say there's a third space fluid collection? For
Third
that
space.
bilateral, yeah, bilateral pleural effusion, no? Actually,
Yeah, it is outside the abdominal cavity, obviously. Okay, in the pancreas, outside the pancreas, in the abdominal cavity, in the retroperitoneum. In acute pancreatitis, collection can occur inside the pancreas, collection can occur outside the pancreas, which can be inside the peritoneum or mostly associated in the retroperitoneum. From the retroperitoneum, it can ascend to the mediastinum. That's also part of the same compartment. But once it reaches pleural cavity, it is definitely another space. So it is a third space. There's no doubt about it. Okay.
and procalcitonin is one of
Procalcitonin is another indicator by which you try to assess the infection. That was the question which I asked. Okay, now Dr. Karthik, please.
Yes, sir. Sir, a follow-up, the ultrasound on the second week showed a cystic collection of the retrogastric area with solid debris, 6 by 6 centimeters in size. Wall thickness varied between few millimeters to 1 centimeter.
Okay, so
the
cystic
patient
collection with a solid debris. So what do you call this?
Sir, it is called as an acute necrotic collection, sir, because it is less than 4 weeks. And it has solid debris means it will be heterogeneous, sir. So it's acute necrotic collection.
So suppose if you have got a collection where there is both solid and cystic, then how will you decide whether to call it a fluid or solid component? Like, no, there will be a confusion. It's a combination. So is there any cutoff for the solid area by which you say that more than certain quantity or percentage you will call it solid, etc.? Do you understand my question? Suppose you have got a collection where there is a solid component as well. And up to
yes,
certain level, we will ignore the solid component and consider the liquid component only. So what is the cutoff level?
Sir, 33%.
Okay, some people say 25%, some people say little more. Okay, so that means 1/4 to 1/3. If it is there, you have to consider it. Otherwise, okay, you will less than that, you will ignore that, that part.
Yes.
Okay, then.
So the patient has mild persistent pain with early satiety but no vomiting. An ultrasound done 4 weeks later shows a pseudocyst, of 6 by 8 centimeters, wall thickness of 0.7 to 1 centimeter. Solid debris is minimal. Pancreatic duct is not dilated. Gallbladder is normal and CBD is normal. How to proceed? Sir, over here, so we have a pseudocyst with just minimal solid debris with a wall thickness of less than a centimeter. So since the period of 4 weeks has been exceeded, we can, in these cases, sir, usually we can even wait for now, sir.
So you have two options, sir. Wait, don't do anything and wait, or you can intervene. So when do you decide to intervene?
Yes, sir, if the patient... Yes, sir. So if the patient presents with features of, if the pseudocyst is impinging on the biliary tree, causing biliary obstruction, manifesting as jaundice, or the patient presents with features of persistent vomiting due to gastric outlet obstruction, or if the patient develops any infection or severe abdominal pain or fever, then these are the indications, sir.
Another symptomatic, so significant symptom, not a mild dyspepsia or anything.
Yes, sir.
A significant symptomatic, severe pain due to increase in size, outlet obstruction, okay, biliary obstruction, and of course, these are the things which then only you take a decision. Second decision is the maturity, because if the wall is not mature, your procedure, whether it is okay, I will come to whichever route of you want to drain, it may be technically difficult because the walls should be mature. Otherwise, it will not hold whatever you are putting there. Okay. So suppose you take a decision to drain this. In this patient, what will be the best option? Wait or go intervene? What do you think?
Sir, the patient does not have any other symptoms, sir, and it is only 4 weeks, the gap, sir. Another soft indication for drainage is if the size remains the same for a period of more than 6 weeks. So again, in the 4 to 6 weeks, we can wait and watch in this patient. That would be an option, sir.
I think it is just after 4 weeks, just 4 weeks. Sir. And the patient has only mild persistent pain, Okay.
sir.
And no other signal. Maybe waiting for some more time and looking at the progression would be much better rather than intervening. Okay.
Yes, sir.
So suppose you decide to intervene, what are the
Yes, sir.
options and how will you do it?
Sir, the options in this case, sir. Oh, here the ultrasound also showed that the collection was retrogastric, which means that, and the wall thickness. So we would assess the distance from the gastric wall. If it is at a distance of less than 1 centimeter, then it is a good collection that can be amenable to endoscopic drainage, sir. And endoscopic ultrasound guided cystogastrostomy can be done in this patient, then, sir.
Okay. What are the precautions you have to take?
Sir, the precautions will be that, sir. Sorry, sir.
Okay, tell us because it is easy to say EUS drainage. So can you
Yes,
just tell the steps 1, 2, 3, 4 like that?
Sir, of US guided drainage, sir.
Okay.
Yes, sir. Sir, so after assessing the distance from the cyst from the gastric wall, sir, or sir, it can be drained transduodenally or transgastrically.
Okay,
After
agreed.
assessing the distance,
Depending
if it
upon
is less than
say transduodenal, transgastric, depending upon the location or the pseudocyst.
location of the cyst.
Okay.
Yes, sir.
In this case, it is
Yes, sir.
probably retrogastric.
Retrogastric.
Okay, so that will
Yes,
be
sir.
that. If it is
Yes, sir.
in the near the region of head and in close proximation to the duodenal loop, then you do a transduodenal
Duodenal.
approach. So location is
Yes, sir.
already given.
Yes, sir.
Retrogastric. So I think you have to go transgastric, no?
Yes, sir. Transgastric
Okay.
we'll do. So we'll look out and we'll first rule out if there is any other coagulopathy or any other contraindication. After ruling out all the contraindications, under anesthesia, sir, we'll through EUS we'll identify the most dependent site, and the Doppler will be done to rule out whether there are any vessels that are impinging in between the cyst and the gastric wall. If that is
Okay.
not there, then we can a 19 gauge needle is used for creating a puncture first. After the puncture, sir, a guide wire is passed through the same, and the tract can be dilated. Oh, here we have 3 options. One, we can use a cystotome followed by a 6 French balloon, 6 French dilatation with a catheter, or we can use a balloon, sir, over here.
Okay.
Cystotome dilatation is usually done. And after that, sir, since this is a pseudocyst, sir, we have again 2 approaches can be followed. One is we can use Hyderabad is in from the paper from Hyderabad, they used a Nagi stent, which is a lumen opposing metal stent, sir. And the other thing, since this is only a pseudocyst, just a simple puncture with a simple pigtail drainage will be sufficient, sir, in this patient.
Single pigtail or multiple pigtail, which is
Sir, multiple pigtail is the preferred approach if it is a walled off necrosis. This was the as per the paper from PGI by Surinder Rana, sir. Multiple pigtail drainage can be done, and then they reassess after 48 hours. And if
Okay,
there
so
is,
if the I will just interrupt. If the pseudocyst is clear and with very little debris, a single
Yes, sir.
pigtail would be enough. Okay, but if there
Yes,
are still some solid residues, perhaps you may have to put multiple, because that obviates the chance of prevents the chance of it getting blocked and then pseudocyst becoming larger again. Okay, now normally for pseudocyst, do you put the stent, Nagi stent or other stents?
No, sir. No, sir. That was for walled off necrosis. I'm sorry.
Okay, so and then what do you do afterwards? You put the stent and then follow the patient.
So then, sir, after that it will usually, sir, the pseudocyst, sir, within a period of 3 to 4 weeks maximum, sir, this cavity will be drained off completely in most of the cases, sir. After the period of between 3 to 4 weeks, a relook can be planned and we can remove the stent, sir, after that.
Okay, you remove the stent and within 1 week pseudocyst recurred. What will you do? What is that meaning of that? There was no acute pancreatitis in between. You remove the stent, patient's all right. On follow-up scan, the patient said he has mild discomfort, but ultrasound showed recurrence of the pseudocyst.
Okay, sir, it could be because of a connection to the duct, sir.
Okay. So in most of the pseudocysts, there is a ductal disruption and a communication with the collection. Okay. And in very many cases, the disrupted duct may rejoin and the drainage become okay. But if that does not happen, the pseudocyst may recur, and in which case you may have to do the proper ductal anatomical studies, and then what will you do?
Drain accordingly. Sir, then we will drain it accordingly, sir. Over here, what is done, transpapillary drainage can be tried, sir, after that.
Okay. Or if the ductal disruption is short, it can be stented across,
stented across.
As per the study from Dr. Ganesh Pai, there is no need to stent across even if there is
Across,
a ductal disruption. You need
Yes,
only a transpapillary drainage by reducing the resistance at the
Pressure.
papillary level. Okay.
So
The
sphincterotomy can be done.
transpapillary drainage along with the pseudocyst drainage may help. Okay.
Yes, sir.
Any other questions, ma'am?
Other questions are, like, is there any difference in the pseudocyst collection in acute pancreatitis due to idiopathic versus alcohol? So what they usually say, the alcohol-related pseudocysts are almost always localized around the pancreatic bed, whereas in the
Okay,
other,
ma'am.
with gallstone and all, it tends to be a little further away. It is more of a diffuse pancreatitis. That is one. Number two, you must know the sites of pseudocyst. One is lesser sac, and posterior disruption will go to the lesser sac. Anterior will present more as pancreatic ascites. And the other question is that today you find there's a mass, tomorrow you find that the mass disappears, there's uniform distension. What does it mean?
Ma'am, it could be a pancreatic ascites, ma'am, in this
How
case.
do you get pancreatic ascites?
Sorry, ma'am.
How do you get the ascites?
Ma'am, because of
So
ma'am, ductal disruption.
No. So it's basically from the foramen of Winslow. So if you find a mass today in the lesser sac,
Yes,
and the foramen of Winslow is the one that connects the greater sac with the lesser sac.
to the SSF, yes, ma'am.
Edema comes down, and the disruption is persistent. Then the next day you get a pancreatic ascites. So just these are some of the other questions.
For completion's sake, if you have heard of a textbook known as Bocas, there is a textbook known as Bocas Gastroenterology. And the pioneers just forget about what I am telling. But the first years and second years, if you have a lot of time, go to the library, get a Bocas and read this. It's interesting to note that Bocas says that we can have pseudosis at 99 different sites. They have been reported in the literature. It starts from the suprasternal space down to popliteal fossa.
Yeah.
It can present exactly in all places where a tubercular cold is present. It can track along the mediastinum, along the paraspinal region, along the nervous plexus, along the sciatic nerve, up to the popliteal fossa. So a pseudocyst can present in all these sites. That is what Bocas says. Okay. So this is just for the completion's sake.
The common ones in the abdomen is lesser sac, gastrosplenic, colocolic, gastrocolic, and between the between the liver and along the falciform ligament, liver and the duodenum. So it can be between liver and duodenum, gastrocolic, colocolic, and gastrosplenic. So these are the common, and the gutters,
And for the completion of the discussion, suppose you have got a fluid collection in the paracolic gutter, which is persisting and patient has symptoms. How do you manage?
Sir, then an ultrasound guided drain can be placed, sir.
So three group of specialists are involved in the management of fluid collection.
Yes,
Remember very well, that is a gastroenterologist who is expert in interventional procedures like US guided. Then radiologist,
radiologist and a surgeon.
Percutaneously, percutaneous drainage, and of course our surgical friends who are always with us, they can also do, especially collection which are more posteriorly, they may do through the pararenal areas. They use a nephroscope or even something like a short laparoscope or a thoracoscope like instrument, and try to remove it by minimally invasive, or sometimes they even go by surgical techniques as well. Okay, so three specialists are involved depending upon the whether it is accessible to endoscopy. So the decision regarding which route you will take depends upon the location and the accessibility. Okay, because just because we have EUS does not mean that we will be able to drain all the pseudocysts or the collection. Okay, things which are closer to the duodenum, closer to the stomach only will be able to drain. Another thing they say, you have to be extremely careful because there may be a pleural effusion, and as you take your scope down, it may give you the wrong impression that you have already detected the fluid collection. So very often the scope is at the G junction when you detect the pseudocyst, because you have to pull it up to get the correct location. And inadvertently, you may actually go and puncture the pleural cavity and create a problem. That is one thing they say. If there is a associated pleural effusion, you have to keep the scope as low as possible so that you prevent this inadvertent puncture through the diaphragm into the pleural cavity. Okay.
I guess in acute severe necrotizing pancreatitis, when do you think the radiologist should intervene? What is the indication?
Ma'am, ma'am, the indication in acute severe necrotizing pancreatitis, ma'am, after 4 weeks, ma'am, if once the wall has formed, ma'am, if the patient has symptoms of it has a symptomatic collection in the form of fever or outlet obstruction of biliary.
You know what I'm talking is, Pramod talks about this quite often, no? Necrotizing pancreatitis, severe necrosis, patient acutely sick, may not be an endoscopic procedure.
Yes, ma'am. The patient may not be fit for anesthesia and an endoscopic procedure, ma'am. And many a times, ma'am, the collection may not be amenable to endoscopic drainage, ma'am.
So
Again, if the collection is more than 1 centimeter apart from the wall, also, ma'am, it may be difficult to drain. So then, ultrasound guided collection, ma'am.
Not minimal invasive. I think radiological intervention is something that you can do.
Yes,
okay, Karthik, thank you for your discussion.
Thank you, sir.
Now we will call
Thank you, ma'am.
Dr. Chetana from Madras Medical Mission. Dr. Chetana, are you there?
Yes, sir.
Okay, now your case, please.
Yes, sir.
Take.
51-year-old manual laborer from Kerala.
This is actually extension of the previous case only. Okay, similar case. Okay, go ahead.
Fullness of the upper abdomen for 2 weeks, acute onset of severe pain in the epigastrium, partially relieved by stooping. Pain was continuous in type, and patient had received multiple doses of analgesic injection in the first 24 hours. Pain became less by second day, but mild pain persisted for the next 5 days. He noticed upper abdominal fullness 1 month later, which is gradually becoming more since the last 1 week. Fever for 3 days. Appetite was okay, but early satiety since 2 weeks. Weight loss of about 4 kgs in the last 1 month.
Okay, alcohol disorder, 12 years. 12 years.
Past 12 years.
Okay, two previous
attacks of severe abdominal pain 2 years ago and 6 months ago, which lasted for 1 week. He was hospitalized, received injections, was told that it was related to alcohol intake, but no details was available. On examination, vitals was stable, BMI was 18, weight was 64, no significant general exam findings, fullness in the epigastrium with no definite borders, no definite mass, no free fluid, other systems, left lower chest stony dull, diminished breath sounds.
Okay, what do you think?
Sir, it might be recurrent acute pancreatitis or acute on chronic pancreatitis.
Agreed. Now the patient has presented 4 to 6 weeks after the pain. So what do you think? The new things are the patient has again developed pain, fever.
There might be collection. There might be fluid collection surrounding the pancreas.
And what is the chest finding?
There is a pneumonia, lower abdominal stony dullness.
Stony dullness is pneumonia.
Pleural effusion.
We discussed it just
Yes,
now.
sir.
So left side
Pleural effusion.
That's most
Pleural
likely.
effusion.
Okay.
Hemoglobin was 12.2, total count was 11,800, platelet was 2.1 lakh, ESR was 43, CRP was 13. LFT, there was a direct hyperbilirubinemia with AST of 67, of ALT of 43, alkaline phosphatase of 183, total protein of 6.5 and albumin of 3.3, creatinine of 1.2 and calcium of 9.3, lipase was 121. Ultrasound shows mild liver enlargement, fatty liver, gallbladder was normal, CBD was 6 mm, pancreas, head, body and tail was hypoechoic and bulky, few hyperechoic spots were noted, the pancreatic duct was not visualized, retrogastric hypodense collection of 10 into 10 centimeters, solid debris seen occupying more than almost half of the lesion, wall 1.6 to 2 centimeters, inner margins were shaggy and irregular at multiple places, left-sided moderate pleural effusion were present.
Okay, this was the observation and this is the CT. Okay.
CT shows bulky pancreas. Pancreatic duct was 3 mm diameter in the head. Solid fluid collection, which was 14 into 11 centimeters in relation to the posterior aspect of the body and tail of the pancreas. Walls in certain places well formed 2 centimeters, but not definitely visible in areas of solid pattern. Few specks of calcification were noted in the tail region. Few air pockets were seen. Left-sided pleural effusion, mild thickening of diaphragmatic pleura. Pleural fluid
aspiration. What is the situation? Already many aspects have been discussed in the previous case, but tell us what is your diagnosis now?
It is an infected collection, sir.
Why do you say?
Presence of air pockets in the collection.
Okay. So how do you confirm infection?
Clinically, there will be increased fever.
Clinically, you are suspected fever is there. Air pockets are seen on ultrasound. On CT scan. Okay.
By the aspiration and sending for the culture and sensitivity.
So by which route do you do that?
Percutaneous route.
Okay, radiologist do it percutaneously. If it is
Or by
patient is
endoscopy.
stable enough, we can use it by US route as well.
Endoscopy.
Okay. Regarding the pleural fluid, just look at the pleural fluid.
Straw colored fluid, pleural protein was 3.8, amylase was 895, ADA was 32, and cells few polymorphs and lymphocytes.
What do you think is the pleural effusion due to?
It might be due to secondary to pancreas collection, sir, because amylase is high. There might be a
What do you think about the
pancreatic
amylase
fistula.
value? What is the usual value you expect in patient with pancreatitis producing pleural effusion due to connection? It is a pancreatic juice, no?
Yes, sir.
So usually the values are much higher.
Okay.
This is only slightly elevated. Okay, of course it definitely elevated, but so in such, if the amylase is definitely more than that of the serum, and if the serum amylase is not much elevated, this you have to suspect the possibility of a pancreatic pleural effusion. So what is the mechanism of a pancreatic pleural effusion?
It can be reactive pleural effusion or pancreatic pleural fistula.
How does it happen? How does the fluid reaches from the abdominal cavity, abdominal compartment to the pleural cavity?
Because of the necrosis and
Okay, agreed.
formation
There
of
is
the
necrosis. Tell me what exactly happened. Necrosis has occurred. Obviously, this patient has got a lot of problem. No,
Yes, sir. There is a collection.
I agree that there is necrosis. There is collection inside the abdominal cavity. My question is that how does that fluid reaches the pleural cavity? If it is sympathetic pleural effusion, you don't expect amylase to be elevated.
Yes, sir.
So there has to be communication. So what is the route? Tell me the route by which the fluid reaches the pleural cavity. It actually mostly this happened due to the severe necrosis affecting the tail region. Okay, and from the retroperitoneum is ascends. So it is a retroperitoneal to mediastinal route. Okay, from there it breaks into the left side of pleural cavity. That's the usual route. Okay, and the tail of pancreas is closer to the diaphragm. Okay, that's why you don't usually get this sort of problem for the right side. So it is mostly left-sided. Okay. So how to proceed further now? How to manage? You have collection in the abdomen and collection in the pleural cavity. The collection in the abdomen part has been discussed in the previous case. We want to discuss that. What about the pleural?
Pleural cavity, actually, pancreatic duct stenting needs to be done to cover the fistulous two sides.
Okay, just continue the management.
Yes, ma'am, pancreatic duct stenting needs to be done, PD stenting, in order to decrease the connection between the pancreatic duct as well as the pleural cavity.
So how would you deploy? The lesion is somewhere in the tail of the pancreas.
Yes, ma'am. Actually, it is difficult. Actually, if it is in the tail, you can do a medical management as well as a medical management like complete bowel rest can be given, total parenteral nutrition. You can use octreotide, 100 mg subcutaneously every 8th hourly to decrease the secretions.
That usually recommended for management of these patients. How often have you used octreotide? Karthik?
Yes, ma'am.
Yeah.
Ma'am, management of the fistula, ma'am.
Yeah. This is management of fistula.
Ma'am, actually, ma'am, a pancreatico-pleural fistula, ma'am, they rarely close spontaneously if they are complicated. So, ma'am, we can divide the management, ma'am. First, again, same rules, ma'am. Nutritional management first.
Yeah.
And, ma'am, in medical treatment, ma'am, what we can offer the patient is octreotide 100 micrograms subcutaneously 3 times a day. Ma'am, it will not increase the closure rate of the fistula, but it will only decrease the output, ma'am.
Secretions may be reduced.
Yes, ma'am. Ma'am, in addition to this, ma'am, we can use the, despite this, ma'am, like she mentioned, ma'am, if there is a connection, ma'am, through the pancreas, ma'am, we can do a, hello?
Yeah, we are hearing you. Continue.
Ma'am, then we can do a endoscopic, ma'am, through ERCP, we can do a pancreatic sphincterotomy to reduce the pressures, ma'am, across the pancreatic duct. So, and if a stenting may also help in these cases, ma'am.
So many newer advances that have taken place in decompressing of the ductal system. Along with the US, recently we had some Isg papers where they tried doing rendezvous procedures, decompressing the duct directly into the stomach.
Oh, yes, ma'am.
Yeah, so those are the other thing, ductal gastrostomy, all these things are now taking place, and then at a later date, they do a rendezvous and try to bring it out through the papilla.
Oh, yes, ma'am.
To decompress, because you have to decompress as early as possible because of pleural fluid accumulation is taking place. I think those
Yes,
and all try to catch up with the advances that are taking place.
This other, sorry, I just got logged off in between. Thank you for continuing the discussion. And these are the trials which I mentioned last time. So just I mentioned it in a passing. These are studies. Pointed trial is for necrotizing pancreatitis. Miser trial is again for necrotizing pancreatitis. Tension trial. Okay. So these are the three trials. Just make a note of this. Dr. Pramod Garg is extremely fond of these trials, and he is a man who is very much interested in pancreatitis. So if he happens to be the question setter, I am sure such questions will come. Okay.
Lastly, for all the PGs, I think is very important. Some of these trials, I'm sure many of you have gone through this, but just see that some of these proper names in the trials, and they just mention the trial and the ask is directly directed to that. What was the outcome? What did the study compare with? So some of the important trials I think you should know, like ulcerative colitis, pancreatitis, sir has given you some trials. Read in detail. Okay? Because all these are questions that are set by people who are interested in that particular field. All right?
I think all the sort of trials and guidelines and criteria, all those things, please brush up before your exam. Like today, I asked, various criteria for diagnosis, prognosis, and name of trials, criteria for the various diagnosis. All those things must be you brush it up. Okay. Thank you, Dr. Karthik as well as Dr. Chetna. Over to
Thank you,
Dr.
sir.
Vivek.
Thank you, ma'am.
Is there, Dr. Vivek?
Yes, sir.
Okay. Case 3.
Yes, sir. Good evening. Yes.
Good evening.
58 years old female, home manager, pain upper abdomen severe in type for last 5 days, acute in onset, continuous type, partial relief on stooping, and pain is felt at mid-back region also. She required multiple doses of analgesic injections but still only partial relief. Fever with chills for 1 day and dark colored urine for 1 day. History of one attack of upper abdominal pain 6 months ago, subsided within few hours, not investigated, and she is on treatment for high blood pressure and on OHA for diabetes mellitus. On examination, she is febrile, 101 degree fever Fahrenheit temperature, pulse is 102 per minute, with blood pressure of 110 by 70 millimeter of mercury and SpO2 96 millimeter of mercury. RBS is 212, creatinine is 1.3, LFT is altered, total bilirubin 3.4 with direct 2.1, AST LTR 148 and 196, alkaline phosphate is 234, total protein 7.2 and albumin 3.9.
What
So
is
there
missing
is
in the lab here?
GGT is not there.
Okay, anything else you are
And
interested?
CRP, apart from
Total
that, sir,
counts,
CRP,
which is
total
missing.
count at CRP, yes,
Yeah,
sir.
total count is 14,200.
Okay, sir.
Okay. So with this lab values and clinical picture, what do you think?
Sir, patient is probably having acute pancreatitis along with features of cholangitis, as patient is having fever and yellow colored urine, and LFT is also altered.
So
So
what are
we
the
suspect
features by
biliary
which you
pancreatitis.
suspect biliary pancreatitis?
Yes, sir. Biliary pancreatitis are, sir, based on first is clinical features like features of cholangitis, classical triad, fever, abdominal pain, and jaundice. Second is based on biochemical parameters when LFT is altered, ALTST more than almost 3 times of upper limit of normal, as well as on third will be on imaging ultrasound if there is typical lesion of choledocholiithiasis and dilated CBD.
Okay, look at the ultrasound.
On ultrasound, gallbladder appeared contracted, multiple small stones. CBD is 8 millimeter, and pancreas is obscured by gas. Liver, there is mild enlargement and grade 1 fatty liver. Urine routine, no abnormalities, and blood culture was sterile after 72 hours. The CBD is dilated, sir, but sir, ultrasound has very low sensitivity for identifying choledocholithiasis.
Okay.
Uh,
Estimated.
yes. So,
So
sir,
what do you think?
yes, sir. For this, sir, I will further evaluate this patient to find out whether there is choledocholithiasis, and I will go for sir endoscopic ultrasound to see if there is any common bile duct stone. As patient is in cholangitis, so with along with pancreatitis. So within
So you
24
have
hours,
you
sir,
have the option of doing CT, you have option of doing MRI, MRCP, and EUS. Your hospital has got all these facilities. Which one you choose, and what will be the reason for each of those?
Sir, I will first choose MRI in this case to see to identify choledocholithiasis, and afterwards, sir, I will go for further go ahead with ERCP and stone removal if there is
Are you
any
interested
stone.
in a simple MRI scan abdomen or MRCP?
Sir, MRI with MRCP.
Okay. Why you don't prefer CT? Because CT is available in most hospitals, and there are radiologists who are more experienced in CT than MRI.
Sir, MRI has a higher sensitivity for identifying small bile duct stones. Most of the time, in pancreatitis, patient might be having small stones, and due to that, they develop pancreatitis along with cholangitis.
So, according to you, if there are no gallstones seen on imaging, there cannot be biliary pancreatitis.
Sir, it can still be biliary pancreatitis due to passed out biliary stone.
Okay, so passed out. So most of the cases it is already passed out, so you may not see it. What is the next common scenario where you don't see gallstone, but still you can make a diagnosis of biliary pancreatitis? What is that?
Sir, if there is altered LFT with along with cholangitis, classical triad of fever, abdominal pain, and altered and jaundice.
Is there a
Uh,
situation where there are no stones are passed out, but still you have to call it biliary cholangitis, biliary pancreatitis?
sir, when there
Sluts,
is microlymphocyst
microcrystals.
sludge.
Okay, for saving time, I just said the answer because in large percentage of cases, even in the absence of stones, they may have this problem. In olden days, people used to collect fluid from the duodenum, aspirate, and like to look for cholesterol crystals and all those things in olden days. Okay, nowadays, now, is there any technique by which you can identify sluts?
Sir, with cannulation and ERCP, we can aspirate and under microscopic
That was the old technique. Is there any less invasive technique? Because
endoscopic
cannulation of the
ultrasound.
pancreas is you only have to pay a price for it.
Endoscopic ultrasound, but micro is difficult to find.
Okay, EOS has got a better sensitivity compared to abdominal ultrasound to detect sluts. Okay, now my question is that during acute pancreatitis, the motility of the gallbladder also will be affected. So how will you differentiate whether this is a sludge secondary to acute pancreatitis or whether sludge was there earlier? Because you will make a wrong diagnosis of sludge and remove the gallbladder. No, that is what we are going to do. So how will you differentiate this?
Uh,
Okay, I will tell you the answer. Wait for the acute phase to be over. Redo it. Maybe after 1 or 2 weeks. Okay. Still, if you find sluts, that is definitely sure. So that is one simple method by which you differentiate. Because in acute pancreatitis itself, you can have less motility of the gallbladder, and the gallbladder may appear distended, and there may be sludge also. Okay. Now
yes, sir.
the CT, I will show you the findings. Okay. What is
CCT was done on second day of admission. It showed liver mildly enlarged, no focal lesions, no IHBRD. GB showed multiple small gallstones, wall thickened up to 4 mm. Common hepatic duct 6 mm and common bile duct 9 mm dilated. Lower CBD stone 8 mm in diameter.
this patient
Has
also
appeared.
had a little bit of collection, etc., etc. We will not concentrate on that aspect. Now, this patient has definitely pancreatitis with the stones in the gallbladder and stones probably in the stone in the CBD as well. So, how will you manage now?
Yes, sir. So for this patient, sir, I will manage for two parts. One is for cholangitis and another for acute pancreatitis. So for
Okay.
cholangitis, sir, I will go for first stabilization of patient. I will keep him NPO and I will start on empirical intravenous antibiotics and IV fluids according
Which
to the
antibiotics
case.
you decide? What is your
Sir,
how will you decide the type of antibiotics?
Sir, based on our hospital sensitivity pattern, I will prefer, sir, piperacillin tazobactam 4.5 gram IV every 6th hourly.
So
And I will,
when you have to do an empirical antibiotic therapy, what is the guiding principle? You have guiding principle of the location of the patient in the preceding 90 days, no? If the patient has never visited a hospital, it's a community, whether it is, so what is the, how will you classify it?
sir, if sir, it can be community acquired, or if
So
it
do
is
you think that
patient
cholangitis
has been
will occur community acquired? No. Cholangitis is
no,
not a
sir.
community acquired thing at all. Okay. This is due
No,
to
sir.
a problem. But the organisms responsible for the infection, if she has been remaining in the hospital for more than 2 days, then you will call it, what do you call it? Okay,
Then
hospital
healthcare
acquired,
associated.
healthcare associated, or community acquired. The organisms may be resistant. That is why. So if she has been associated with the hospital, you may have to give a high end. That's all. And then you have to make sure that it reaches in good concentration in the bile. So which are the antibiotics which will reach in good concentration in the bile in such a situation?
Sir, third generation cephalosporins have higher concentration in bile, as well as piperacillin tazobactam, ampicillin.
Hmm.
Uh,
So give supportive care, you give antibiotics. What else?
Sir, after that, as patient is having cholangitis, I will plan for
So
ERCP.
what will be your indication to do an ERCP as an urgent case?
Sir, when patient with biliary pancreatitis is having features of cholangitis, that is indication for emergency
Okay,
ERCP as well within
so
24 hours.
cholangitis unquestionably is an indication to do an emergency ERCP sphincterotomy and removal of the stones or at least 10 the CBD. Okay, fine. So if there is cholangitis, you have no. Or if there is no cholangitis, also if the LFT worsens, or you have definitely shown that there is CBD stone and the pancreatitis also worsen, LFT worsens, then probably you will have to go and intervene. Okay. So if there is cholangitis, or if the LFT parameters worsen, or pancreatitis parameters worsen, don't wait for too long because the patient may be too sick and you won't be able to do the procedure. Okay. Now there is gallbladder stone. What will you do with the gallbladder stone?
Sir, after managing cholangitis and after resolution of the episode of acute pancreatitis, I will advise patient to undergo cholecystectomy during the same admission, uh, and later on I will follow up.
Patient says, I had enough, I want to go home and take rest and come back after 6 months or 6 weeks. What will be your advice?
Sir, in that case, I will advise patient that she has increased chance of developing
Okay,
again
there is a
recurrent
higher
attack of
chance of
pancreatitis.
developing the same problems and again having to go through all these problems. Okay, now she has got a little small gallstones. Can you give oral dissolution and
Sir,
forget about cholecystectomy completely?
Sir, oral dissolution therapy is only preferred when patient is not having any symptomatic episode of any acute cholecystitis
This is a
or
complicated
prior
case of
pancreatitis.
this is a complicated case of gallstone disease. I think we should not play with this. The oral dissolution therapy, if at all it works, it takes a long period. And what are the chances that oral dissolution therapy will work? So suppose I want to do a oral dissolution therapy. What are the minimum things I should ensure?
Sir, one is stone should be less than 10 millimeter in size, and apart from that, it should not be obstructing any cystic duct, and there should not be any
There
episode
should
of
not be any
non-acute
obstruction. There
acute
should not be an
cholecystitis.
obstruction.
Gallbladder.
Okay.
No
Most
obstruction.
important,
Yeah.
your function.
Then it should be a functional gallbladder. Gallbladder, if it is contracted, there's no point in giving this. Third, on a plain X-ray, if there is calcification, it will not do anything. Then it will not work in an obese patient generally. Okay, so such people we are better not to give. Okay, and you have to warn them that the success rate is only 30%, recurrence rate is again 10 to 15%. So ultimately, in the long run, only 1 out of 10 may improve. This is usually given for people who are too sick to undergo cholecystectomy and when you have nothing else to do, like in very elderly persons, etc. So this is not the ideal patient for oral dissolution at all. Okay, never ever think of that. Patient may hear from the net and other things, and I will ask you, but you must say very boldly, no, you should undergo this sort of surgical therapy. Okay, I think you have done that part. This is the patient's EVS, etc., and this is VRCP. We ask that question. Yeah, my question is that if you do ERCP in such a situation, can it aggravate the existing pancreatitis?
Yes, sir. ERCP has a chance of aggravating acute pancreatitis in 5%, around 5% of cases. They can develop post ERCP pancreatitis. If we use more of pre-cut, we have to use our
Okay, so what you
thyroid
have to say
procedure.
is that the benefit versus the risk. Okay, the benefit is that otherwise her pancreatitis will become worse and she may go into a very serious situation and may die. Okay, now post ERCP pancreatitis, there is a risk, but we will try to minimize it by all means. So what are the methods by which you minimize the post ERCP pancreatitis?
Sir, first is by aggressive IV fluid therapy prior to ERCP, as well as I will also keep a diclofenac suppository to reduce the chances of post ERCP pancreatitis, and it should be done by trained ERCP doctor only, and selective CVD cannulation should be achieved in this
It
case.
should be done by an expert so that there is no chance of repeated cannulation and problems. Okay, thank you. I think that part, I think is case, that part is over. We'll go to the next stage. Thank you, Dr. Vivek, for the nice discussion. Dr. Rohan.
Questions that are often asked is
Yes, sir.
which enzyme increases first when you have an obstructive jaundice. That's
Ma'am, can you repeat that question? I couldn't hear.
which of the enzymes in LFT increases first in an obstructive jaundice due to polygon?
I have also heard people asking
Yeah,
that question.
this question is common. Number one. Number two, difference between a microlith and what's that, sludge and crystal. Okay.
Hmm.
These are some of the questions, and especially when there's a chronic pancreatitis, how will you try to pick up a microlith in the duodenal juice? So these are some of the offshoot questions.
Vivek, do you know how to, what do you actually find out by aspirating the duodenal fluid?
Sir, on that crystals.
You aspirate the duodenal fluid, what will you do with that?
What type of microscope?
Under
No, those
microscope.
are asked, yeah. And how does a cholesterol stone appear? How does a pigment stone appear?
You have to think of your biochemistry days.
Yeah.
First year MBBS, how the cholesterol crystal will look like. Okay. You have to do say polarizing microscope and for high refringent crystals under the polarizing light. And I think these cholesterol crystals are like some sort of envelope with one end broken or something like that. Or something.
Like a cracked glass, yeah.
Okay, revise that. Okay, just to know it in case some examiner asks you.
And other
sir.
thing was, yeah, I think these are some of the questions. And if something else comes to your mind, I'll just find it. Okay, the other question is this. Okay, this is common question. You know, like the patient is on clopidogrel, patient comes with a fracture neck of femur, patient comes in an acute. What would you do? So, see, you mentioned that you do only a sphincteroplasty, you will not do a sphincterotomy. You know, and then would you like to stop the aspirin? So these are, you know, these are the questions that have been asked in DMD, a hypothetical case where you have a patient with just the same picture, 72-year-old who comes with history of cholangitis and is on clopidogrel and has got ischemic heart disease. He's also had a angioplasty, coronary angiogram, and is known to ischemic heart disease. How would you manage? So just read all these, you know, in and around.
Okay, so it's a general rule on patient on antiplatelet drugs. That's a standard rule which you have to follow, and I think you have to answer accordingly because that's a standard rule which is always there for how to manage to do endoscopy, the routine endoscopy and the high risk endoscopy in patient with a patient taking and single antiplatelet, double antiplatelet. What will you do? All those things. Okay, it just you have to just revise it. Okay, now Rohan.
Yes, sir.
Okay.
So case 4, this is a 65-year-old male with recent onset of upper abdominal pain for 2 months, which is dull aching in character, insidious in onset, almost persistent, occasionally aggravated by food. Pain increased since the last 1 month. It was associated with jaundice, with generalized itching for the last 2 weeks, loss of appetite and weight loss of 3 kgs over the last 2 months, no chills, rigors, no pale stools, no GI bleed, known case of type 2 diabetes mellitus on oral hypoglycemic agents, and diabetes was under control. On examination, he was moderate build, average nourishment, icterus present, scratch marks present. On per abdominal examination, liver is palpable 2 centimeter below right costal margin, which is firm in consistency, non-tender. Gallbladder is not palpable. No other mass, no ascites. Per rectal examination is normal. The
What
other
is your clinical
systems
diagnosis? If you want to look
normal.
at the history part, so
Yes.
60-year-old male, abdominal pain, dull aching, maybe mild sort of pain, then jaundice, pruritus, mildly loss of appetite, and some weight loss.
Yes, sir. So
Short
syndromic
history.
diagnosis. Yes. So a syndromic diagnosis would be obstructive jaundice, most likely extrahepatic biliary obstruction, most likely malignant in this case, with a possibility of benign obstruction as the other differential. And etiologies I would like to consider in this case would be either among the malignant etiologies, I would like to consider the probability of carcinoma head of pancreas because of the presence of jaundice. I would also like to consider cholangiocarcinoma as one of the differentials. And in the benign etiologies, since the patient is having persistent abdominal pain, I would also like to consider the possibility of chronic pancreatitis with an inflammatory head mass compressing the bile duct, causing the obstructive jaundice. Or I would like to consider other benign differentials such as IgG4 related disease or autoimmune pancreatitis as one of the differentials, which can cause this kind of presentation.
So you are considering both malignant as well as benign. Which one do you think is more likely?
So there is history of weight loss and poor appetite. So I would like to keep malignant over a short duration, 2 months.
Short duration, elderly patient, weight loss,
elderly,
loss of
yes.
appetite, so many things. So
Malignant
has to be number one.
Yes. Yes.
So is there anything which will in the history which will help you to say that this is CA pancreas or cholangiocarcinoma or other periambulary carcinoma, something like that?
Yes, sir. CA pancreas is one of the malignancies which is a pain predominant malignancy. So presence of abdominal pain, whereas hilar cholangiocarcinomas are generally painless malignancy. So
which are the obstructive jaundices caused by malignancy producing significant pain? So
one is CA pancreas,
no,
one
CA
is
head of
the other
pancreas.
is CA gallbladder carcinoma, but that would be more in North India.
Okay, it's more than North India. Agree. Okay, so you have told us a differential diagnosis.
On investigations, the hemoglobin is 11.2, total WBC count is 4,600, platelet count is 212,000, ESR is elevated 56, random blood sugar is 232, creatinine is 1.2, the liver function test shows total bilirubin of 11.2, which is direct or conjugated bilirubin predominant, that is 7.1. The AST is 76, ALT is 87. Both mildly elevated. Serum alkaline phosphatase is markedly elevated along with GGT.
190 is the normal. Okay. 190 normal.
Okay, sir. So it is elevated. Alkaline phosphatase and GGT appear to be elevated. Total protein is 7.3, albumin 3.7, and globulin 3.6. The viral markers are negative. On ultrasound abdomen, there is mild hepatomegaly with intrahepatic biliary radical dilatation in both lobes, common hepatic duct and CBD seem to be dilated 8 millimeters. But with this age, I would expect that 8 millimeters after the 6th decade, it is just borderline.
Yeah, borderline. That much can be normally present also.
After 6th decade, with every decade 1 millimeter rise, I would expect. The gallbladder is moderately distended. There is no wall thickening, no stones or any growth. And pancreas head is bulky, 5 centimeter. It is hypoechoic, and pancreatic duct is not dilated. How to proceed further?
So with these findings, okay, the biochemistry confirms that there is a cholestatic jaundice and alkaline phosphatase is definitely elevated, and ultrasound also shows. With this ultrasound finding, where do you want to locate the disease, and what do you think is the disease?
I would like to locate the disease in the distal, that is the periampullary region. So I would like to consider the CA carcinoma head of the pancreas as the first differential, because of the enlargement in gallbladder as well as the liver. And,
how do you proceed further?
I would want to consider a better imaging modality to define the disease. So I would like to.
Do you want tumor marker?
Yes, sir. I would like to. Yes, ma'am. A tumor marker, I would consider CA19-9 as one of the tumor markers, but in the presence of jaundice, there can be false elevation also. But the level, if it is markedly elevated, it can be suggestive of malignancy. So CA19-9 is one tumor marker which I would like to ask for.
Other important things, whenever you ask an ultrasound, always ask for a Doppler, because if the Doppler shows portal vein thrombosis or it shows encasement of the vessels, then almost it's an inoperable case, no? Then you really don't go any further investigation. So always we ask for ultrasound, always ask for a Doppler.
Which vessel engagement you will look for?
In this patient?
In this patient, I would look for portal vein or SMV encasement and celiac axis as well as common hepatic artery encasement.
Okay, so you have to look at the arterial as well as venous.
Venous.
Okay, because it is head of pancreas, and there is a rule according to surgeons. How many degree of encasement is inoperable?
Yes, sir. So there is we call it either abutment or encasement depending upon the degree of involvement. So if it is less than 180 degrees, it is called as abutment. And it can be with or without contour irregularity of the vessel.
Good.
And for vein, it is operable. Even if it is less than 180 degrees, it can be considered as resectable. But whereas for an arterial, like if it is encasing the superior mesenteric artery, in that case, it becomes borderline resectable, and the patient requires further neoadjuvant therapy before planning for a definite mode of management. So that is the significance of this abutment and encasement.
Okay,
in this patient, yes.
You have looked at the CT, no?
Yes, sir. In this patient, there is the CECT shows hypodense area in the head of pancreas, which is 4 × 5 centimeter. Body and tail appear normal. There is no upstream dilatation of the pancreatic duct. The common bile duct is dilated 9 millimeters, and there is abrupt narrowing seen in the region of the head. So there is dilatation of the common bile duct.
So it is fairly the same findings. Nothing.
Yes, sir.
We could not get further details. Okay, what you do now?
So
again, there is a mass lesion. There is a lesion in the head of pancreas.
Head of pancreas.
What are the differential diagnoses?
In this case, I would like to keep both carcinoma head of pancreas, and since there is no evidence of other features of chronic pancreatitis, it's unlikely that it would be like a chronic pancreatitis related mass. I would like to keep IgG4 related disease as one of the differentials, or autoimmune pancreatitis rather. So as one of the differentials for this mass.
So with any relevance to the pancreatic duct in that context?
Yes, ma'am. The pancreatic duct, if there is no upstream dilatation, it goes more in favor of autoimmune pancreatitis in this case.
So what are the duct signs related to pancreas? Double duct, everyone knows.
Yes,
okay.
Sir.
Uphill duct dilatation.
When there is
you get.
In any malignancy, there will be upstream dilatation of the pancreatic duct. And then there is a cigar butt sign and a double barrel sign. Double barrel is when the bile duct is as dilated as the portal vein. And cigar butt we can get in a distal bile duct malignancy. And double duct sign is when both pancreatic duct as well as the common bile duct are dilated because of the head of pancreas mass.
So the other two are of bile duct. These are of pancreas. What is duct penetrating sign?
So if there is irregularity of the duct walls because of the lesion, then it is a duct penetrating.
So the exact meaning is that if you have a mass lesion, the mass lesion can be due to an inflammatory mass or a neoplastic mass. Okay. So in CA pancreas, it's almost invariably a ductal adenocarcinoma. Ductal adenocarcinoma. And there usually will be narrowing of the duct. Okay. And upstream dilatation. If it's an inflammatory mass, very often you can see the normal course of the pancreatic duct through the mass. That is known as the duct penetrating sign. That is how you differentiate. So inflammation, the caliber of the duct does not, this is usually not affected, unlike in the case of a pancreas cancer. Okay, that is the sign. Okay, we will. This is the US.
Yes. So on the endoscopic ultrasound, there is a hypoechoic, bulky head of pancreas mass, which is 6 centimeter in width, mild dilatation of pancreatic duct in body, which is 5 millimeters. Pancreatic duct in the head is 3 millimeters. Common bile duct is 9 millimeters, and there are no stones. The adjacent celiac lymph node enlargement is present, which is 10 millimeters. And mass is skirting the portal vein and SMV confluence.
They have not written the degree of involvement. So what is your comment on that?
Skirting, I would assume that
you
it is
think
less
you
than
can make a comment of skirting or abutment on US?
We need yes, sir.
You require a cross-sectional imaging to know the complete.
Contrast CT scan is a better modality to comment on.
Okay, good. Okay, so there were two things: hypoechoic mass, some lymph node was there, and the diagnosis was actually it was CA head of pancreas. So FNA was done from the lymph node as well as the mass, and they said the mass through the D2 station. Why the importance of D2 station? Why can't you do? You know, it is difficult to do an FNA US through the D2. It is very easy to do it from the andro because the scope is straight. Why do they want to do it through the D2?
Because we need it from the head of the pancreas and not from the body or tail. So that is why even though the scope loops, this will be the representative biopsy from the mass. So,
okay, but from the androm also we'll be able to access the head of pancreas and the scope will be straight and it will be easy. So why are you preferring D2 station?
Sir, I'm not sure, sir.
Okay, because here you are biopsy. If a surgery is required, they will invariably remove the C loop of duodenum.
Okay, sir. Yes.
With the head of pancreas, no. So even if you are passing through the duodenal wall, if there is subsequent tumor infiltration of the duodenal wall, that risk is not there. That area is going to be resected. So whenever you have a case where future surgery is possible, you should not contaminate the uninvolved organs, so that otherwise it will produce a tumor localization to those tracts. So the tract will get subsequent metastasis to the tumor. Okay,
tumor
so avoid that.
Yes.
Okay, so
on the histopathological examination, there is plenty of lymphoplasmacytic cells, no features of neoplasm, no granuloma. Immunohistological examination on the cell block shows IgG4 cells positive, that is more than 70 per high power field, and serum IgG4 levels are elevated more than twofold, that is they are.
What is the cutoff for serum IgG4 level?
So 135 milligram per DL is the cutoff, sir. But more than 2 times upper limit of. Yes, sir.
Okay.
The Japanese criteria and the international criteria both consider more than 2 times upper limit of normal as elevated.
Okay, so it is the diagnosis and patient was put on steroids and patient improved. So avoid surgery. So you should know various criteria. Earlier it was ISO Japanese and now there's an ASAN criteria. But the current one I think is international criteria, no? You should know the difference between type 1 and type. International consensus diagnostic criteria for type 1 autoimmune pancreatitis is the one which I think is more followed now, and therefore at least you should know the basic criteria. And then the details one may not be able to say offhand, but at least you should know this. Okay. So thank you. That was a good diagnosis. You thought of IgG4 in the beginning itself, but in the examination, be careful. Even if it's IgG4, you still have to consider CA head of pancreas, because if you jump and diagnose IgG4, and if it happens to be IgG4, examiners may doubt that whether you have got some extra help or from someone else. Okay. So,
Yes.
you have done a right thing. You put a neoplasm first and followed very late by the benign autoimmune like that. Now we have only 5 minutes. We will rapidly rush through the next case. Thank you, Dr. Rohan.
Thank you,
Ravikiran,
sir. Thank you.
Yes, sir. Yes, sir. Good evening, sir.
good evening. We will rush the case. Okay.
Yes, case 5, 62-year-old male, a manual worker until recently, diabetes mellitus for the past 22 years, initially on oral drugs and now on insulin, poorly controlled, recent anorexia with weight loss of 5 kilograms in 3 months, and coming with a dull aching upper abdominal pain since 4 weeks and now increased since 1 week, and almost persistent pain, occasionally aggravated by food on oral analgesics. No vomiting, no abdominal distension, no alteration in bowel habits, no jaundice. Regular alcohol intake from the age of 25 years, 40 units weekly, stopped 6 months ago. History of pulmonary tuberculosis, 2 years ago, treated for 6 months, was on daily drugs. Physical examination, BMI is 16.8, very low, so weight 52 kgs. Vitals are normal. No aqueous pallor, edema, or lymph nodes. No cutaneous lesions. Abdomen is scaphoid with the liver palpable 3 centimeter below the right costal margin and is firm consistency. There's no mass, no free fluid. The other systems are normal.
Okay. So you have got the physical findings as well. So what do you think? Diagnosis.
Yes, sir.
You want to look at the history once again? Basically,
Yes,
diabetes
60 to
mellitus, recent anorexia, weight loss, dull aching pain, persistent
and
pain.
recently, yes, and recent loss of control on diabetes. So considering this probably a pancreatic malignancy would be the first differential
Okay,
diagnosis.
old
As
person,
short
you have got anorexia, weight loss is there.
anorexia, weight loss, and loss of control in diabetes, sir, and abdominal pain, upper abdominal pain, which is there, and aggravated with food and requiring analgesics.
Okay, this control of diabetes, if the diabetes was well controlled and with the same medication without any other illness, diabetes going out of control is the one. Okay, somebody who was regularly having a poorly controlled diabetes does not have much significance. A new onset of diabetes or a diabetes which was well controlled goes out of control without any obvious other precipitating reasons, no steroid, no other disease, etc. Then you have to think of CA pancreas. Okay.
With history of alcohol intake for the past 25, almost.
Where do you think is the CA pancreas in this patient? You must have other differentials, no? This particular history does not pinpoint and say it is.
Or either it could be a gastric or malignancy as well, ma'am.
Yes.
Because upper abdominal pain.
Lymphomas, tuberculosis,
adenocarcinoma.
Yeah, there's nothing in the history to consider retroperitoneal pain, persistent upper abdominal pain, that's all, no? So all neoplasm you have to consider, CA stomach, CA pancreas, retroperitoneal tumors, even
hepatocellular carcinoma with underlying cirrhosis.
Just tumors, all these come as a DD. Just because we're in the pancreatic session, don't jump to.
Yeah, because you have a clue that everything is pancreas, so don't do that. Okay.
And the person has got a firm liver.
Hepatomegaly with firm.
Yeah, firm liver.
Lab showing hemoglobin of 10.2, anemic, total count of 7,000 normal, sir, and platelet count of 1,85,000 normal. ESR is elevated, 82, and fasting blood sugar is 383, and with poor.
Just move straight to ultrasound, calcification head, body.
Yes, calcification head, body, and tail region of pancreas with the main pancreatic duct diameter of 8 millimeters and no mass, bulky head region. So there's a dilated pancreatic duct with evidence of chronic calcific pancreatitis in the form of calcifications in the entire pancreas, and CPD 8 millimeters, again probably could mild borderline CBD diameter. A could be age related.
Okay, so from this ultrasound, what is the diagnosis?
There's a bulky head of the pancreas with evidence of chronic calcific pancreatitis with dilated.
Okay, so question is, what is your diagnosis?
Probably adenocarcinoma of pancreas.
Okay, what are the causes of bulky head in chronic pancreatitis?
Mass.
It can be inflammatory mass as well.
Inflammatory mass.
It can be inflammatory mass
inflammatory
as well.
mass as well.
Okay. So how will you differentiate? Do you have a audio issue? Are we missing him?
Are you speaking?
Hello? Yes, sir. Am I audible, sir?
Yeah.
Hello?
Continue. My question is that in a chronic pancreatitis patient like this, how will you differentiate inflammatory from neoplastic mass? You can use clinical investigation anyway, any method.
So I would go for either a cross-sectional imaging in the form of CT, contrast CT, or you can go for an EUS with FNAC. But since it's on a background of a chronic calcific pancreatitis, it is usually a malignancy unless proven otherwise, and also serum markers so can help with CA19-9.
Okay.
CECT abdomen showing head of pancreas, which measures 4 centimeter.
No new information. There's again chronic calcific pancreatitis.
SMV,
Okay.
SMV normal, visualized, no notes, few small hypotensiria.
So we have reached
small
to back to square one. What to do now?
Like to do an EUS.
Okay, EUS
endoscopic
and
ultrasound guided FNAC or FNB, sir.
okay.
Where would you ask?
Mask.
Why do you ask for the US? What are you targeting? What is your aim when you're doing an EUS in this patient? What is your aim? Everything is there here.
To get
so what extra information you get with the EUS?
To get a sample.
Sample from where? For what purpose?
A mask.
Okay. Do you have any clue to say that this is neoplasm?
Background of chronic calcific pancreatitis, then most likely.
The ultrasound thought it was bulky, but CT actually doesn't show a definite mass or anything. Okay. Let us see whether we have got any other investigations. CA19-9.
Is 227.
Okay. Now you have had a reason why you can do the EUS. Till that time, you had no reason. Okay.
Yes. Endoscopic ultrasound showing mildly hypoechoic area in the head region, multiple calculi.
There also there is no mass because it could be part of the inflammation also.
Yes. FN, it's scanned tissue.
Okay, what are the, you said EUS in one breath. Is EUS as simple as you do it in the previous case? What are the special problems associated with the chronic pancreatitis when you do EUS FNA? Are you answering? We are not able to hear you.
Rohan, anyone else just back up?
Can Rohan take over because it's similar to your earlier case?
Yes, sir.
Okay, now.
Sir. Yes, sir. In EUS, when there is a doubt of malignancy, there are some newer modalities like EUS elastography that can distinguish between a benign and a malignant pathology. There has been some studies from PGI Chandigarh which help in that case.
How often that is applicable in a pancreas which is highly scarred and has a lot of stones, like in a
No, sir. So here we can only demonstrate presence of chronic pancreatitis over here, which is easily, understood from the scan itself, CT scan itself. So EUS has a limited role in this case, sir.
If you have got a well-defined hypoechoic area and it happens to be malignancy, and if you target well, but very often it is highly sclerotic, so even in to penetrate that pancreas is very difficult, and very often there will be some stones in your path, and in fact the tip of the needle gets slightly blunt also. So whenever I have done it in CCP, because in Kerala we have CCP and the situation, I always have found out that with the 1 or 2 passes, the needle get completely damaged, its tip get bent, and you don't get even enough tissue. Okay, so very little tissue, technically difficult, and maybe if you have got a good FNAB, sometimes you may get some answer. But generally, the yield is very low compared to pancreatic adenocarcinoma. The yield is extremely low. Okay, so here CA19-9 is 227.
It will be almost a blind procedure, and I think in this patient with the history taking, The whole thing can just be explained just by the chronic calcific pancreatitis.
Yes, definitely.
He must be just having cytophobia. He's having pain, so there's a weight loss. So it's behaving more like an exocrine or endocrine insufficiency rather than malignancy. I mean, as in the US, you'll not get any extra information, and you cannot keep on probing. The stones will come in the way. It will give you a misinterpretation of the possibility for a lesion. I think I would just hang on and observe the patient rather than proceed for. I mean, where do you take the biopsy from? Where do you take the aspiration from? There's no lesion, no? There's no mass lesion.
Yes, ma'am.
Okay. So what will be? How will you proceed further?
So one
Okay.
is
Because just to say in one sentence, how will you manage this patient and try to answer the following questions for theory part.
Okay. So management, since it is a major duct disease, that is a stone predominant duct disease, there are intraductal calculi as seen on the CT scan. So assuming those are the cause of the pain, persistent pain, the management, since the size of the stones is more, the available modalities will be, first will be pulverization of the stones using ESWL.
Ravi, want to answer that? He's keeping quiet. Ravi, answer.
Devi, how will you manage this patient? Are you audible? I think Devi's audio has the problems again.
Yeah.
Okay, you try. Devi Kiran, please try.
Yes, sir. Yes, sir. Of calcifications, ESWL can useful only in the ductal calcification, sir, and with no proximal. I mean, ductal calcification in the head or neck region only, not beyond.
Dilated ductal system with the stones. Okay, if there are multiple strictures in between, also it will be difficult. Okay. Okay, so you can do non-surgical method like ESWL and pancreatic endotherapy, or if the patient has intractable pain, one even think of doing surgery depending upon the clinical situation. Okay, now between you can answer the first 4 questions. Ravi Kiran can answer. Prevalence of pancreatic adenocarcinoma in alcoholic pancreatitis and tropical.
VT, let them read through it. I think.
Okay. Okay, I don't answer. Just go through these questions and try to answer yourself. Okay.
Make a note of the questions.
Please keep a note of the question. So, thank you, Dr. Ravi Kiran, and thank you all the discussants for having taken part in this discussion. I know it is exam time; it is a lot of stressful time. Ma'am, would you like? Should we continue the OSCEs?
Yeah, we'll continue. Just one few things. When you do a polycystectomy, few questions that are asked is what is the color of the stone that was seen? Okay, very important. Number one, and oral dissolution is actually not for the pigment stones. You know, down south is more pigment stones, and if calcium is present, again, it's not indicated. Just read through it. It's more historical. Let us go through it because some examiners may just ask, but this question is often asked: what was the color of the stone? Okay. So I think very well done. I think you've covered up the entire pancreas last 2 days. But just remember, see, the OSCE is a very funny thing. You know, they structure it in such a way that the most difficult answer, which is one word, will have 4 marks. You know, and what is easy, say, clinical presentation will have just 1 mark. So that's, be very careful about that. And most of the OSCEs are all those rare ones. You know, they take up genetics, they take up tumor markers, they'll take up some natural history. And some of the trials will definitely come up. Then they have the video digest. So just be very clear about the advances that are taking place. What is the procedure? What are the indications? What are the risk factors? So there's a video digest. There's a radiography session, and then there's this theory session, which is clinical, as well as advances, as well as they cover up hepatopancreatic biliary small intestine. The OSCEs go in that manner. I think there are 30 questions, if I'm not mistaken. So you have to read almost everything, A to Z of Schlesinger.
So next Tuesday we have a session on liver transplant complication, which we seldom discuss. It may come in OSCE. It's a case scenario based discussion, and it will be on next Tuesday. Dr. Hari Kumar is doing it, and Dr. Hema also is joining Dr. Hari Kumar for next Tuesday session, and next Thursday also we'll have on OSCE. Okay, which subject we will inform you in short while. Can we close the session, ma'am? Thank you. Thank you all
for taking through the session. And you've really done a wonderful job. You know, saves me a lot of time. Thank you all. All the best and keep reading.
Wish you all the best. And good reading. That's all what we can do now. Okay.
Bye. Good night.
Good night.